All right, good morning, folks, and welcome to the Palliative Care Friday Chalk Talks. I am very excited about today's subject on narcotic bowel syndrome. We in the field of palliative care, we regularly face challenges of complex chronic pain and patients on chronic opioids, and I'm fairly certain I've seen this before, but I'm not sure I had a name for it earlier on in my career because I think this is so not well known. Um, so today we are honored to be joined by our guest speaker, Professor Adam Farmer, who is a current professor of gastroenterology at St. Louis University and the director of the neurogastroenterology and motility at St. Louis University Hospital. He undertook his medical training at University College London, subsequently undertook his specialist training in gastroenterology before moving to the Wingate Institute of Neurogastroenterology, BARTS, and the Royal London School of Medicine. He was awarded a PhD at the University of London for his work entitled Human Psychophysiological Responses to Pain, the Development of Human Pain Endophenotypes. And just a few of his accomplishments include more than 130 peer-reviewed papers, 25 book chapters, and being named as a rising star by the United European in 2018. Adam, sir, welcome, and thank you for being here with us today.
Marty, thanks firstly so much for the invitation, and it's really great to be with you virtually. And thank you for the kind introduction. I really agree with you, Marty, that this is something I think we've all seen in the field for some time without being able to put a name to it. So really, narcotic bowel syndrome, I'm going to refer to opioids as the good, the bad, and the potentially the ugly. So I've got no conflicts of interest to declare, and I won't be inviting any off-label discussion of medicines today. So our only objective is really to enhance the awareness of narcotic bowel and perhaps to improve some of the practical skills in recognizing, diagnosing, and managing this very difficult disorder. And subsequently, hopefully by the end of the session, I'll be able to understand and describe the pathophysiology of narcotic bowel syndrome and have some idea of the management options that we have for these patients. So I want to start off with some red flag symptoms. So in the gastroenterology clinic, the sort of red flag symptoms are rectal bleeding, dysphagia, unexplained weight loss, etc., etc. But certainly in my clinic, I'd like to introduce you to some of my red flag symptoms. So a patient comes in with 8 sets of notes. They come in with these Genova diagnostic food antibody assessment tests that they're allergic to every food under the sun. They come on with these wraparound dark glasses, which keep out all evil. Soft collar, which they don't really need. But the main one that I see in my clinic when they come through the door is if they're on opioids, and that's a big red flag for me. So you will all be familiar with this, but really in the early 90s, there was a considerable support for using opioids in treating non-cancer pain. And this was really driven by the uptake of the WHO pain ladder, which really embedded opioids into the treatment algorithm for chronic pain. But I think what we must be very mindful about this ladder was developed for inpatients with cancer-related pain, yet it's been really moved over to non-cancer chronic pain, probably erroneously in my viewpoint. I think we'd all know that opioid prescribing and usage and abusage is increasing. 5% of the world's population uses 80% of the world's opioids. And I think this is a really sad statistic that one person dies from misuse of prescription drugs every 19 minutes. So we'll lose one person, maybe two, during this talk itself, and that's a really sad statistic from my point of view. And this really equates to more deaths per annum than we see in road traffic accidents. So this is some data we published in the Lancet back in 2017. Here you can see here the deaths from prescribed opioids per 100,000 rising. It's very markedly over that period from the late 90s up to 2014. That's also coupled by increase in prescription of opioids. There's a little drop around 2013 when we started to become more aware of this problem. But really, as we have become more selective in our prescribing of opioids, the deaths from heroin overdose has really begun to take off considerably, and that's probably as a result that patients are using illicit sources of their opioids in exchange for those that are prescribed by physicians or healthcare providers. This is data from the UK, and again, it looks at drug-related deaths. Certainly in the UK up to 2014, tramadol was not a controlled drug, so it could be prescribed. And you can see here that the deaths from tramadol overdose particularly escalated in the early parts of this century. So a really worrying trend there. I think these are things that you will all be very familiar with around the commercial success of OxyContin. This really had a really unprecedented promotion and marketing campaign. Something we don't have in the UK and the EU is direct-to-patient marketing, which I think is probably a good thing. But really, the numbers speak for themselves. And the regions of the US that had the earliest and highest availability of OxyContin had the greatest initial abuse and diversion. And certainly OxyContin became the most prevalently abused prescription drug in the early 2000s. This is a campaign that was put forward by the Royal College of Anaesthetists and the Faculty of Pain Medicine contained therein. And I think for us as managing patients with chronic pain of whatever etiology, I think this makes a lot of sense, really. The opioids are good analgesics for acute pain and for pain at the end of life. I think there's little evidence in the literature that they're helpful in the longer term. But I think we have to acknowledge as well that there are a small proportion of patients that can get an analgesic response if that opioid dose is kept low, and especially if that use is intermittent and an unrequired basis. But again, I think we'd all be cognizant that these patients are very difficult to identify at that point when you start that opioid prescription. But we also know quite clearly that the risk of harm increases substantially when that daily morphine equivalent dose is more than 120 milligrams per day. But this is not associated with substantial benefit. And again, I think we have to think about what are we talking about in terms of benefit here. Certainly in my mind, it's not necessarily a reduction in pain per se. It's improvement in functional status and subsequently quality of life. And again, I think this is stating the obvious, really. But if a patient's using opioids and still in pain, then in my mind, the opioids therein are not effective. And there's a very strong argument, I think, that in this context, the opioids should be discontinued, even if no other treatments are available. And again, I think we'd all agree that good pain management for patients is beyond just throwing drugs at them. But we also know that chronic pain is very complex, and these patients need a very detailed assessment, particularly of their psychosocial issues and their emotional influences on their individual pain experience. I think opioid prescribing primary care is very important, as many of our patients have initially started on these drugs and they're often escalated in primary care. And again, I think we have to be mindful that many practitioners routinely prescribe opioids for chronic non-cancer pain because they believe it's unethical to withhold analgesia, and I take that as a very valid point. But again, I would reiterate that opioids are largely ineffective for most, if not all, chronic pain indications. So this is again some data more recently from the UK, and really looked at the trends in opioid prescribing over time and by demographic and area of the UK. But you can see here that certainly with both fentanyl and probably the most commonly prescribed opioid tramadol, that there's an increase over time in these drugs. They were prescribed more in the north of England than the south, and prescribed in areas of social deprivation. So there's a clear demographic and geographical split here in how opioids are prescribed. And I think these drugs do, as we know, represent considerable potential harm. And then therefore, I think we have to raise the question around equality of access to healthcare, and certainly something that's I've been very mindful of over the last year since moving from the UK to the US around social deprivation. But if you think about the overall adverse effects of opioids, we're all, I think most medical students could tell us around addiction, abuse, and diversion. But there's also a number of other side effects that perhaps we forget sometimes, including increased risk of osteoporotic fractures, myocardial infarction, immunological dysfunction, muscle rigidity, skin and itching is often a very problematic side effect, but also the GI side effects and the sort of counterintuitive notion that opioids can in fact cause hyperalgesia when given in the longer term. So in terms of that overall encompassing term, we use the term opioid-induced bowel dysfunction, which covers a spectrum of symptoms related to the GI tract, including nausea, vomiting, bloating, reflux, and constipation. And opioid-induced constipation, or OIC, would be the most common subtype of OIBD. But we also know that this is associated with reduced work productivity, increased absenteeism, heightened presenteeisms, i.e. that the patient is at work but is not productive, and associated with a diminution in quality of life and increased healthcare utilisation. In terms of the molecular effects of opioids on the GI tract, these are essentially mu-opioid receptor agonists activate a complex intracellular signaling cascade, which is both G protein and G protein independent in their nature, such that they essentially reduce the excitatory motor neurons and secretomotor neurons within the GI tract, which ultimately lead to reduced motility, increased transit times, and reduced secretion, which ultimately manifests as opioid-induced constipation. So if we try and put that all together, if you have a group of chronic opioid users, somewhere between 50 to 60%, depending on the indication for the opioids and depending which paper you read, will have a degree of opioid-induced bowel dysfunction, of which 40% will have opioid-induced constipation. And then this final smaller group, probably representing 1 in 20, although the epidemiology is not entirely clear of chronic opioid users, will have what's known as narcotic bowel syndrome. So what's narcotic bowel syndrome? Well, it's a subset of opioid-induced bowel dysfunction, which is really characterized by 3 main aspects in my mind. So chronic abdominal pain that often worsens or escalates with heightened dose of opioids, and frequently associated with some of those GI symptoms such as bloating, vomiting, constipation, and nausea. And I think probably one of the real problems we have with this disorder, outside the sort of specialist area of expertise that we represent, is that many healthcare professionals aren't aware that opioids may in fact cause hyperalgesia by sensitization of those nociceptive pathways. So the Rome Foundation is essentially a group of the great and good across the world in disorders of gut-brain interaction that meet every 10 years or so to update the diagnostic criteria for various disorders. The one that you'd be most familiar with would be irritable bowel syndrome. But the Rome 4 criteria, which is due to be revised next year, and we're working hard towards that revision, states that narcotic bowel syndrome is chronic or frequently recurring abdominal pain that is treated with high dose opioids, with a number of clinical features that the pain worsens or incompletely resolves with continued or escalating doses of narcotics. There's a marked worsening of the pain when the narcotic dose begins to wane, improves when the patient's redose, and this is referred to as the soar and crash phenomenon. But there's a marked progression over time in terms of the frequency, duration, and intensity of those pain episodes, and that's frequently associated with significant reduction in quality of life. And as for all of the Rome criteria, it needs to be chronic, such that the criteria fulfilled for the last 3 months, with symptom onset at least 6 months before diagnosis. And I think with any chronic pain syndrome, pain must occur on most days, as we would expect. So I think for many, the idea that opioids can cause or exacerbate pain is a rather counterintuitive notion. But certainly within the literature, there's been a number of mechanisms that have been described that support this idea of opioid-induced hyperalgesia, including bimodal opioid modulation at the level of the spinal dorsal horn, activation of those dorsal horn glia with opioid facilitation, and then finally the TLR4 mechanisms. And we'll look at those each in turn now. So this is the normal effect at the spinal dorsal horn, that you have a high dose opioid that acts on a G protein coupled receptor to cause essentially an inhibitory effect, such that high dose then masks the excitatory effect of those nociceptors, and then we end up with a state of analgesia. In contrast, very low dose opioids mask those inhibitory effects, and therefore can cause hyperalgesia. But in terms of chronic opioid use, in essence, even in that high dose opioid context, the excitatory G protein coupled receptor is bound, such that that receptor is then tolerant, displays a degree of tolerance, and is sensitized, such that you can then develop opioid-induced hyperalgesia and subsequently narcotic bowel syndrome. This is also a slightly newer mechanism that's been described at the level of the spinal dorsal horn, in that glial cells provide both structure and nutritional support for neurons, and those glia can be activated by a number of factors, whether that be infection, peripheral injury, or indeed chronic opioid use. And then these glia can become activated and release a number of inflammatory mediators, cytokines, and particularly a chemokine known as fractalkine, and that can then lead to a state of hyperalgesia. And just a note about some of the TLR4 mechanisms. So this is the hypothesized central immune signaling contributions to opioid reward. So this is the sort of classical viewpoint that opioids bind to neuronal opioid receptors, resulting in activation of corticomesolimbic dopamine reward pathways. And in this model, glia such as astrocytes and microglia not associated beyond their homeostatic controls. But there's been a recent appreciation that non-neuronal actions of opioids and opioid-induced pro-inflammatory glia activates other pathways as well, including the TLR4 dependent activation of central immune signaling. And then collectively, this can result in a heightened reward and heightened tolerability, and therefore lead to ultimately a pro-nociceptive state. So going back to the patient, I think we have to sort of map out some of the interactions that these patients have with healthcare professionals. So a patient presents with pain, that opioid prescription is initiated, and then ultimately over time, as we've discussed, but through the various pathophysiological mechanisms, narcotic bowel syndrome can ensue. This quite understandably leads to patient frustration. There's increased healthcare use, a degree of social stigmatization. I think as well we need to acknowledge and be mindful that this leads to frustration on our part as well. You know, we want our patients to be better and have an improved quality of life. So this then ultimately leads to an abnormal therapeutic interaction, which inevitably then leads to another opioid prescription or another dose escalation, which isn't always, as we've discussed, in the best interests of the patient. So this leads to both a frustrated patient and a frustrated doctor. And ultimately, patients will go shopping for their healthcare providers. So if they don't necessarily get the answer that they want from one, they'll go to another, and then unfortunately, this cycle then happens all over again. In terms of investigations for narcotic bowel syndrome, generally speaking, by the time patients diagnosed with this, they'll have had multiple investigations and multiple imaging. I think a plain abdominal film can be useful just to exclude partial obstruction or fecal retention due to an adynamic ileus that's associated with opioids. But really the key to making the diagnosis is that recognition that escalating doses worsen pain and aggravate symptoms. So in terms of management, I think it's establishing that therapeutic relationship is first and foremost part. And I think in many ways the ideal context of that is in a multidisciplinary team where with both physicians, specialist nurses, psychologists can be very helpful. Really trying to educate the patient as to the underlying mechanisms that can cause opioid hyperalgesia. And I think this is really a key factor that influences outcomes in these patients, because I think if you can get the patient on board and understand the mechanisms explained in the most simple ways that one can, then I think if you have a patient who's well educated and is on board, then outcomes are better. There isn't any data as yet to say inpatient versus outpatient detoxification is necessarily better. I think for some patients who've been on opioids for a long period of time, then I think inpatient admission is ideal. And certainly, you know, the pharmacological options that we have here are really only one part of the solution, and reiterate the point that patient education and having a patient on board with what you're trying to do is key. But in terms of our pharmacological options, we have some of the neuromodulators or antidepressants in terms of tricyclics or SNRIs, benzodiazepines to cover the acute stages of withdrawal, but certainly clonidine, which is an alpha-2 adrenal receptor antagonist, can be useful. And then obviously you need to treat some of those GI side effects of constipation, and often use a pamora such as naloxegol in this context. So really, this is the broad management plan for patients with narcotic bowel syndrome. I think it needs to take place over a very long period of time, and really step one is the most important aspect of this in terms of building a therapeutic relationship, beginning to use some of those neuromodulators, and then certainly the opioid detoxification, which can happen as both an outpatient or an inpatient, as we discussed, where you aim to convert that opioid from its morphine equivalent to methadone, and aim for a reduction in dose of around 10 to a third per day. Treat any associated opioid-induced constipation, benzodiazepines during the withdrawal and taper. And then you can consider other medications. Again, the evidence base here to support these is low, but drugs like pregabalin, quetiapine, or ketamine can be useful in some patients on a short-term basis. And then really the final bookend to this is continued outpatient support to help reduce some of the recidivism rates, as well as utilizing other healthcare providers, such as psychological support and bespoke pain management clinics. This is really quite interesting data, which again I think illustrates the role of opioid-induced hyperalgesia from Doug Drossman, published a few years ago in the American Journal of Gastroenterology. But you can see here that following detoxification, the reduction in abdominal pain, non-GI pain, and then validated chronic pain scores such as the McGill Pain Questionnaire here as well. So these reductions are small, but I think we'd all agree in these kind of patients, small reductions probably represent big wins in the longer term. But sadly, there's a significant relapse in these patients where up to 2/3 of patients will be back on opioids at 1 year, and this is really tough when you've invested so much time and effort into an individual patient that their primary care provider then restarts their opioids. So again, it's around following these patients up in the longer term and providing them with that support and access to pain management services. So how do we prevent narcotic bowel syndrome? Well, there's little or no evidence here. I think the key focus, certainly in my mind, is that healthcare providers need to be very judicious in their use of long-term opioids, and again reiterate the point that long-term opioids have little role, certainly in my mind, of treating non-malignant visceral pain, which is my area of interest. But if opioids really do need to be used, the lowest dose for the shortest time possible, and then thinking about co-administering antagonists such as Pumor, as we mentioned. So in conclusion, I hope I've convinced you that opioid prescribing habits are changing, that opioids paradoxically can cause pain. Narcotic bowel syndrome is a sequelae of chronic opioid use in somewhere between 1% to 5% of patients, and really recognizing that escalating dose of opioids is driving and causing some of the pain is central to making the diagnosis, and that really treatment is multifaceted in terms of educational, psychological and pharmacological approaches, with an aim to detoxify these patients and then try and keep them off opioids insofar as possible in the longer term. And that's me, Marty.
Thank you, Adam. That was outstanding. We've got one question in the chat. I'm going to ask mine first, and then I will ask Rachel to unmute, and then she can share her. So mine, and maybe isn't a fair question because there probably isn't enough research on this, but I'd still love to get your hypothesis about this. And it really boils down to, are there certain opioids that are safer or not? Because I can imagine the scenario where we've got somebody in our palliative care clinic, or maybe even in hospice, but they still have some time. Maybe they've got many months of prognosis, but they've got a widely metastatic cancer. So they've got a great reason to be on opioids. But I could still imagine seeing that patient potentially having something like narcotic bowel syndrome develop, and we'd still have to navigate it. And yet there's probably not a very good option to wean off of opioids. So again, it sort of circles back to the question of,
Yeah.
is there certain opioids that maybe are less likely to trigger something like this?
So you're absolutely right. There isn't any good evidence here to say that one opioid is necessarily better than the other. I would refer back to some studies in terms of opioid-induced constipation, because that's a better studied area. There's a suggestion that transdermal fentanyl has less rates of opioid-induced constipation, and therefore you maybe expect by extrapolation transdermal preparations would cause maybe less narcotic bowel syndrome. My slight worry about those studies was that they were all sponsored by pharmaceutical companies that produce these medications.
Of course.
So it's peer reviewed, it's in the literature.
Sure.
The delta in terms of the effect is quite small. So in my mind, an opioid is an opioid is an opioid, whether it's codeine, hydromorphone, or fentanyl.
Maybe So the one that I was thinking about was buprenorphine, which it's not one of these that has been studied very much in the past and is newer. There's some thought that buprenorphine, because it is a partial agonist, is less likely to cause some of these G protein changes. And there are some thoughts that maybe it binds more specifically to the spinal cord than some of the mu receptors in the gut. I don't know that any of us could say definitively, but it would be a theory maybe worth trying.
Yes, I think it's an interesting thought. I think my concern
Hmm.
with all of this is with the opioid epidemic, and certainly we felt we were
Hmm.
protected in the UK and Europe. It wasn't quite as bad as over here. I can assure you that it's definitely not the case. It's as bad in the UK and EU as it's been in North America. But again, I think we just need to be very careful that even with some of these partial agonists now that we have, that we're not, talking about this, the buprenorphine epidemic in 20 years' time.
Sure. Lovely. All right, Rachel, why don't you unmute and ask your question, please?
Can you hear me okay?
You are very, very soft.
Yeah, I'm not sure how to adjust that, but I'll try.
Ah, that's perfect.
Perfect.
Um, Adam, I would love to hear more about your familiarity with Pamoras and the current long-term safety profile for patients, specifically medically complicated patients, because that's the bulk of what we see in
Yeah.
palliative care. Thank you.
Yeah. So again, I put um, a few slides because I thought this might come up. So I think Pamoras are a really useful drug. It it's frustrating in my mind that we're prescribing a drug to treat the side effect of another drug. And so I think the first and I think the most salient point is that, does that patient really need to be on an opioid to manage their chronic pain? And as Marty said, some of them, it's an entirely reasonable management option. In terms of Pamoras themselves, I think they are well tolerated. I think they're safe in the long term. I think part of the problem with Pamoras, though, is a lack of awareness around their availability. They're often continued even when the opioid is stopped. So I think that's part of a problem there. But I think we would all, again, this is slightly with my GI hat on, that a non-steroidal prescription also, should trigger a PPI prescription, whereas we don't think, an opioid prescription should also trigger a prescription of a standard laxative, whether that's an osmotic laxative, Miralax, for example, or a stimulant, Senna or Bisacodol. So I think they're probably underused, but my feeling is that they're reasonably safe in the longer term. But I think the key point is that when the opioid stops, the Pamora can stop as well. And this is a sort of pragmatic guideline we published last year around informing the patients, recommending a prophylactic laxative, making sure that bowel assessment is done at follow-up visits. And then if that sort of standard over-the-counter laxative isn't sufficient, then to proactively then commence a Pamora thereafter.
All right. This was wonderful, Adam. And so impressed that you anticipated our question and had slides ready for
I
it.
often try, but it never sometimes works out.
All right, sir. Have a wonderful day. Thank you
Thank
so
you
much.
so much for the invitation and enjoy your day.
Absolutely. Bye.